All right, guys, we're going to move on to obstetrics and neonatal care, so the whole childbirth process and what follows it. So, unfortunately, this is going to be one of the, if not the longest lecture in the whole book, and that's just because, birth is a complicated process. There's lots of stuff going on. There's lots of things that could go wrong. So, we just have a lot of stuff to talk about. So, we're going to talk about what a normal delivery looks like. And we'll talk a little bit about C-section, but obviously as EMTs, we're not going to do that. And we'll also talk about vaginal bleeding, like what is normal, what is abnormal. And then we'll talk about some delivery issues like a nuchal cord, prolapse cord, or breech delivery. So we'll get into all of these separately, as well as there's two placenta problems that can affect the baby. So most infants are delivered in the hospital, but sometimes they're not. Sometimes there's the back of an ambulance, sometimes it's in people's bedrooms. It just really depends on the timeline of that baby. And we'll talk about it in a little bit. Once we hook them up to like fetal monitoring, then we can have a better idea of the health of the baby and stuff like that. But if we don't have any of that advanced monitoring, it can be hard to tell exactly how far along you are, at least at first. So the decision that we have to make then is, do we need to stay on scene and deliver the infants right here in the room or in the back of the ambulance, or do we think that we can make it to the hospital on time? When possible, babies should be delivered in a hospital. So just know some of these basic anatomy and physiology. I won't necessarily put this on the test, but you might see it on the National Registry. Just some basic information. So yeah, just know some of these kind of vocab words almost. Know what an ovary is. Know what the uterus is, stuff like that. Know what the fallopian tubes are, all that good stuff. Okay, so there's a picture of that stuff. So you should be able to look at this picture without labels and figure it out. Figure out what part goes where. Okay, so the uterus is where the baby lives, and is what when they say, "Oh man, I feel contractions," that's why the uterus is contracting. So the placenta attaches to the inner lining of the uterus, and it connects to the baby with the umbilical cord. And that's what helps keep the baby alive inside the womb. Now, because the placenta is connected to the woman, and the woman is the mother of that baby, whatever mom eats, the baby eats too. So basically, if you have any issues with these things, mom's not eating enough nutrients, not getting enough oxygen, buildup of waste products, too much carbon dioxide, drugs, toxins, medications, all that stuff can make its way to the baby. And we'll talk about that. And then another thing you might see in the National Registry, just this umbilical vein and umbilical arteries. And so normally, we're used to our arteries being oxygenated, veins being deoxygenated. And in this situation, they're reversed. So just know that they are opposite. Okay. And they live in a membrane called the amniotic sac or bag of waters. If you ever hear, "Oh, my water broke," that's what they're referring to. Contains anywhere from 500 to 1,000 milliliters of fluid. It helps insulate and protect the baby. And then there you go. That's that. My bag of waters. My water broke. That's what they're referring to. Okay, so just be familiar with some of these basic changes in the body. So the mom, as a way of dealing with this baby that's inside them, they are going to have some respiratory changes and cardiovascular and musculoskeletal changes. If you think about it, there's a baby that's growing inside them. It can be pretty demanding, and so the mom's body has to compensate for those changes. So some of that stuff, the hormone levels are going to increase, which helps fetal development and prepare for childbirth. Okay. So now, near the end of gestation is when the baby grows. So initially, it's about when a woman is first pregnant, it's about building those building blocks and the neural tubes and making the brain and spinal cord and all that really specific stuff. But near the end of the pregnancy, a lot of that stuff is done, and it's really just about growing size. And that's when you'll see the baby size really start to grow in that trimester. So mom's blood volume will increase because they need to meet the increased needs of the fetus, and the number of red blood cells itself will increase. The patient will clot faster, but you also may see a 20% rise in the patient's heart. Okay, so that's all we're saying is just that the baby puts some increased demands on the mother's body. Weight gain is expected, obviously, but normally they say you should only gain about 30 to 40 pounds in a typical gestation. So like pregnancy-induced obesity is a thing we have to look at. Okay, so stages of labor, just write these in your notes, memorize these. This is like one of the highlights of this chapter is there's 3 stages of labor and you got to know which is which. So we'll talk about these a little bit more in depth, but briefly, first stage is dilation of the cervix. So that's the preparation for birth. The second stage is the delivery of the actual infant, and then the third stage is delivery of the placenta. Okay, so and we'll talk about these more in depth. So first stage is that the contractions and the cervix is getting bigger and bigger, and the body's basically preparing for birth. Okay, so if you could have one word attached to this first stage, it would be preparation. And then of course, labor is generally longer in prima gravida, and what that means is that's their first pregnancy. Now, multigravida is a woman who's experienced previous pregnancies, and the more children that a woman has, the faster this birth process tends to go. Some women who have multiple kids tell me that on that the first birth, they were at the hospital early and they were paranoid and they were worried. And as soon as their water broke, they called 911. But by the time they're on their 4th kid, they'll be doing the dishes and their water will break, and they'll just keep doing their dishes and then drive themselves to the hospital. So I mean, the experience tends to change the more kids you have. Okay, so Braxton Hicks contractions are false contractions. Okay, I don't necessarily think you need to really memorize these, compare and contrast, but just know that Braxton Hicks contractions are false contractions. And so if you're working, like especially in a maternity floor, but if you're on an ambulance or something, you need to be able to differentiate between real labor and these kind of false contractions. All right. So if in the first stage, the amniotic sac can rupture a bit prematurely, but we need to transport them to the hospital. And the descent is called lightning. You might see that on the test or something. All that is when the baby's in its like final runway for birth, it'll actually move down, and we call that lightning. All right, second stage, it's when the baby starts to enter the birth canal, and it ends when the baby comes out. Okay, let's see. So third stage is going to be the birth of the infant and ends with the delivery of the placenta. So the placenta must completely separate from the uterine wall because, as you know, the placenta doesn't stay in there; it has to come out too, and it's usually about a half hour after. So so 2 kind of key words you should pay attention to are preeclampsia and eclampsia. So all preeclampsia is pregnancy-induced hypertension, usually shows up the 30th week of gestation, and they're going to have signs and symptoms similar to other high blood pressure conditions. So headache, seeing spots, lots of swelling and edema, anxiety, and of course, high blood pressure. Now, eclampsia is when the hypertension has got so bad that now the mother is having seizures. So basically, we want to lay them on their side, preferably the left side. That's going to relieve a little bit of pressure on the aorta from that baby. We want to make sure the airway stays open, provide O2. Get suction ready because some people vomit when they seize, and then just rapid transport and call for paramedic intercept because these can be complicated. Okay, just talked about that. The baby we kind of want on the left side, and that will relieve a little bit of pressure on the mom's internal organs from that. Okay, internal bleeding may be a sign of ectopic pregnancy, what that means is that there's the baby's started to grow, not in the uterus. Normally it's in the fallopian tube. So it's those little tiny straw-like tubes that go from the ovaries to the uterus, and fertilization will occur in the fallopian tube. Obviously the fallopian tube is not meant to have a baby, so that can become a problem pretty quick. So ectopic pregnancy is a leading cause of maternal death. So this is a pretty serious thing. So if you're seeing a lot of vaginal bleeding in a woman who's not quite ready to give birth, you could be thinking ectopic pregnancy. So the other 2 things that we got to know, just know that the difference between the 2 is abruptio placenta and placenta previa. Luckily, the names kind of help us out a little bit. So abruptio means like abrupt, so try to remember that word. And that's where the placenta separates prematurely from the wall of the uterus. So the placenta abruptly detaches without warning. And the placenta previa, the placenta develops over the cervix. So it's kind of like, if you want to think of the word previa, like it's a preview, the placenta develops first, and so the placenta becomes the preview, and that kind of blocks the cervix. All right, diabetes. You can have pregnancy-induced diabetes. We call that gestational diabetes, and normally it'll clear up after delivery. And it is normal, just typical diabetes as a secondary to increase glucose issues with having a baby. Okay, women, of course, may be subject to the same kind of bad things that can happen to non-pregnant people. So assaults, accidents, shootings, all that stuff. So just remember that because of that 20% increase, or I mean that the increase in blood volume and the 20% increase in heart rate, you may actually have a lot of blood loss before signs of shock actually develop. Okay, so trauma is one of the leading causes of a rupture of placenta. It's like that force of impact can separate that placenta prematurely, and usually pretty painful. Okay, seatbelts is something that can get pregnant women in trouble. Just need to, if there's a car accident with a pregnant woman, you really need to inspect that abdomen and the hip area and ask them how are they wearing the seatbelt? Do they have any abdominal pain? Is there anything going on where the seatbelt was? Because there can be some trauma, some internal trauma from wearing the seatbelt incorrectly. All right, cardiac arrest. Basically, at that point, there is no baby. So we're going to do CPR, we're going to do AEDs, we're going to do all that stuff because dead moms deliver dead babies, so we got to keep the mom alive. All right, focus on the woman. That's what I just said. So suspect shock based on the MOI, especially considering all that increased blood volume. Be prepared for vomiting and aspiration. And you can try and figure out how far the baby along is by kind of asking some of those 3 questions. And then there you go. That's just your typical EMS standard stuff. Open airway, give oxygen, assess circulation, all that fun stuff. All right, some cultures may not permit a male healthcare provider to assess the female patient. I've encountered that myself overseas. Yeah, you know, it's a cultural difference that we don't quite understand, but at the end of the day, we kind of have to respect their wishes. So a competent, rational adult, you know, right? Just that goes back to like the beginning chapters. Are they intoxicated? Was there a head injury? Those kind of things. Well, if none of that's there, they can refuse treatment if you're the only provider and they don't want to deal with a male EMT. You might have to sit it out. It kind of depends on those patients' wishes. All right, United States, good job us, has one of the highest rates of teenage pregnancy rates. There's all sorts of crazy political reasons about that, but you may encounter this. You may encounter a teenager, 15-year-old pregnant female who in front of her parents will tell you that she's a virgin. And so that can kind of create some interesting ethical issues because now you're in the middle of this dramatic situation and you have to get the baby out, but the parents don't know it. And so just be prepared that there could be some drama if you have a young pregnant teenager. And yes, sometimes some pregnant younger women will actually be pregnant and not know it. I mean, for months, and they may only know they're pregnant near the end, near the last few weeks. So it may be a surprise to some people. All right. So once again, form of general impression, airway, breathing, circulation, all that fun stuff. This is just your typical EMT stuff that we do. Okay. If delivery is imminent, sorry, you're going to have to deliver that baby right there. If it's not imminent, go to the hospital right away. And we'll talk about some of those things you're kind of looking for that. So when you're considering transport, it's also a good idea to ask kind of these questions. So has there been significant bleeding and pain? Do they have a preeclampsia? Are they having preeclampsia? Do they have a seizure? Or they have any sort of altered mental status? So if those things are going on, you might want to take him to the hospital quicker. And here's some other questions you can ask. What was her expected due date? Most of the time, these women, they go to doctors and everything, and so they know their timelines. If there's any complications that they are aware of, either with her or with the baby, if they've been receiving prenatal care, and just get a full medical history to try to figure out what you're dealing with this birth. So determined, we just said that, so the due date, also the frequency of contractions. So they should be about 2 minutes apart. So that means the baby's coming. So if you got 4 or 5, 10 minutes between contractions, awesome, take her to the hospital. But if you're looking at like 2 minutes or less, it's probably time to get some gloves on, and you're gonna have to deal with it. All right, and so if the water broke and it's green, that is called meconium, and that's fetal stool, and that usually indicates newborn distress. So if you have a greenish broken water situation, we're definitely worried about the newborn at that point. So we're still going to do all those things. Check for crowning, which is when the crowning, it's like the baby's head's going to come out. Vital signs, it's all good stuff. And that's why we really want to check that blood pressure for that preeclampsia, eclampsia situation. Okay. We'll talk a little bit more about fundal massages, but they're saying their uterine massage can be used to slow down vaginal bleeding. That actually works. So does breastfeeding, interestingly enough. Okay. There we go. Let's get through some of these. The hospital staff will want to know the number of weeks of gestation, her due date, and any complications. And hopefully you would have already, found that stuff out. So you can just direct that over the radio when you're going to the hospital. All right. So unfortunately, you're going to have to probably ride this out on scene if the baby is going to be coming out pretty soon, or if there's some sort of natural disaster, bad weather, or something that's preventing you from going to the hospital, you're going to have to deliver that baby on scene. All right, some other questions you can ask. How long have you been pregnant? When you do, is this your first baby? Are you having contractions? How far apart? And how long do they last? And these are just some other questions, spotting bleeding, water broke, all that stuff. So these are good questions that kind of help shape your overall like treatment decisions as far as how, if you have a critical patient or not. All right, and these are just more questions. These are all good things that kind of point you in the right direction of things you'd be looking for. All right. Now, once labor has begun, there is no way it can be slowed or stopped. I mean, there's some drugs we can push that can kind of slow it down, but at the end of the day, this is a natural process. It's all hormone driven and internal clock driven, and you're just going to have to deal with whatever that baby decides to do. All right, so we're not going to talk about these. I just want to show you kind of what the hospital does. So talking about those fetal heart rate monitors and stuff. So you on the bottom there, you can see maternal contractions, and then on the top, you can see fetal heart rate. So this is a cool fetal heart monitor machine that looks at that, and then you, depending on the fetal heart rate and the contractions, you can determine how you're doing. So if you have in the normal range and they're variable, that's good. That means that the baby is probably doing pretty well. If there's variable decelerations where it's mostly variable, but it will, normally within that normal range, but every once in a while it dips down, it dips out of that normal range. That's okay. We're not really worried about that. You can see that sign there, or that data point there. Very common, 83% of labors. So if it's occasional variation outside of the range, that's okay. We can deal with that. But if we're looking here, so at the symmetrical decreases in heart rate that are kind of poorly timed with the contractions, that's considered a late deceleration, and that may be more of an issue. So once again, it's not on the test. You guys don't need to know this. I'm just showing you at the hospital, this is the stuff they're looking at to evaluate how the mom and the baby are doing. Okay, so if you have to deliver that baby, try to preserve the modesty best you can. It'll probably be pretty hard to do just because the nature of giving birth. We want the patient to be on a firm surface, and we want to elevate the hips about 2 to 4 inches. Okay, I know I've seen that question before. So 2 to 4 inches. It's not 12 inches, all right? It's 2 to 4 inches. Just slightly elevation to facilitate that baby coming. Okay, place towels and sheets on the delivery area because it will get pretty messy. Put on sterile gloves. Obviously, it's not a sterile procedure. But sure, if you have sterile gloves, put them on. We don't want to be introducing any bad stuff if we don't have. Okay, So give that mom oxygen. Always be looking for that crowning, for that baby to be coming out. And what they're saying there is do not allow abrupt or explosive delivery to occur. That just means once you see crowning and like once we're going down this road, have eyes on that situation the whole time. Don't look away, don't walk away, because it can be hard to tell when a baby is going to come out. So once that baby is committed to the birth canal and is coming, that's your job. You're staying down there until the end. All right, delivering the head. This is on our good deliveries, like uncomplicated, natural, awesome deliveries. The head's going to come out first, and the baby might actually rotate as it comes out, just with the shoulders and everything. So just support that head as it comes out. Now, what we don't want is to tear the perineum, so or perineum, however you want to say it. So sometimes that baby comes out so quickly, and that skin can't stretch fast enough, and it can do a lot of damage. So we want to make sure that we actually hold a little bit of pressure down there on the perineum itself to kind of prevent maybe some of that tearing. And so you're kind of assisting the head come out, all right? So it's not necessarily like you're just watching it happen. You want to assist the baby coming out. So there you go. See, we're not poking the baby. We're not putting our hands in there either, really. We're just maybe a finger, and we're just facilitating the head coming out. We don't want to go in a whole lot. Okay, now if the amniotic sac does not rupture as it's coming, it will appear as like a kind of a water balloon looking thing. So it will suffocate the infant if not removed. So you may puncture the sac with a clamp. You do that sac does need to rupture. So now once you've done that, you need to clear the infant's mouth and nose because he breathes out of that. So we want to make sure as soon as the head comes out, the rest of the body's still in there. We want to make sure that umbilical cord is not wrapped around the neck. If it is, we call that a nuchal cord, and obviously you can imagine that's pretty bad. Easy treatment though, before it gets too tight, is you can just slip the cord over the head, you're good. Worst case scenario, you may have to cut it. But either way, we want to suction the amniotic fluids away from the airway as quick as possible. Okay, usually that the baby, like I said, in a good delivery, after like the head and the shoulders comes out, the rest of it will just kind of slide out on its own time. Obviously, we don't want to be pulling. And just so you know, the baby will be covered in this kind of vernix white. I mean, it's kind of weird. You wouldn't expect it, but just that's totally normal. I'll send a video of a birth attached. Okay, so dry off the infant and wrap it in a blanket. So once it comes off or comes out of there, you want to dry it off. And we can be a little bit vigorous with this. And part of that drying is we're also stimulating the baby. So it's kind of like it really is a rude awakening. It's basically, all right, I knew you used to be in this nice little, jacuzzi of good stuff inside the mom, but welcome to real life. And you're not roughing them up necessarily, but you're stimulating. As you're drying them, you're kind of trying to wake them up a little bit. We do need to make sure that the blanket or towel is warm because they're used to that jacuzzi of the mom, right? And now they're in the real world. So we need to make sure we're managing hypothermia. So we're suctioning the mouth and then the nose, okay? So mouth first, then nose. Now keep the infant the level of the vagina or the placenta until the umbilical cord is cut. And that's because there's still fluid flowing back and forth. So if we raise the baby super high or super low, that's going to change the amount of fluid that we have going between the mom and baby. All right, so clamp and cut the cord and tie the end with special umbilical tape. And usually, hopefully you'll be in a hospital or something and a doctor can take care of that. And the delivery of the placenta, which as a reminder is that third stage, that usually comes out by itself within a half hour, normally within a few minutes, but within the half hour. If it's over a half hour, then that can be some sort of complication and we need to follow that up. But the placenta itself will just. Okay, so this is where we're talking about that the fundal massage, and that's just like in that picture. We're actually trying to massage the uterus through the outside of the abdomen, and that compression can actually help slow some of that bleeding. All right, so the following are emergency situations where, okay, we need to start calling some people. So if more than 30 minutes have elapsed without the placenta being delivered, if there's more than 500 mils of bleeding before the placenta, or if there's any sort of significant bleeding after the placenta. So 500 milliliters is about the top limit of bleeding that we want. Of course, we're going to have some bleeding. It's a messy process. But after 500, now we're starting to worry about postpartum hemorrhage and maybe a tear somewhere, something like that. So after 500, we need to start. Okay, Jess, put gloves on before handling the newborn. The newborn should breathe on its own within 15 to 30 seconds after birth. And part of that breathing, of course, after suctioning, part of that breathing stimulation is going to be from drying the baby off. And the heart rate should be between about 120 and 160. And we'll talk about what to do when it's not. So after drying them off, it's right there, generally tap or flick the soles of the feet or rub the back. That goes back to that stimulation. And then if you're still not getting it, you can see some down there, positioning the airway, drying, warming, suctioning, tactile stimulation. So part of this is just waking the baby up and welcoming it in the world. So basically, these are some things we need to do. So we need to dry and warm the infant, clear the airway, try to stimulate them, use the BVM if we have to, but usually the baby will start breathing on its own. And then you have to consider doing compressions if the rate is low enough. So we want the baby on their back with the head down, neck slightly extended. You want to make sure we suction them real good and keep drying them off. Okay, and then one good thing we can look at is that skin color. So does the baby look healthy, or does it look blue or gray, or the color it shouldn't be? So you can also, and you do need to evaluate the fetal heart rate. If you don't have that fancy fetal heart rate monitor, you need to figure out what the baby's heart rate is, because that can tell you a lot about the overall health of the baby. Okay, so this is something you don't necessarily need to memorize word for word, but just understand where you're at. So what they're saying is if it's more than 100, that's usually okay-ish. It's lower than we want it to be, but we don't necessarily need to start doing compressions or anything. If it's 60 to 100 beats a minute, we need to throw some extra oxygen on board, and we want to reassess every 30 seconds until those vital signs stabilize. Now, if it's fewer than 60 beats a minute, we need to do BVM and we need to do chest compressions, because 60 beats a minute is about half of what the baby should be at. So we need to get involved at that point. Okay, and there we go. Chest compressions, 120 minute, perfect. All right, so that's a picture of that. Okay, we're gonna get through some of this. All right, one of the last things we have to talk about is the APGAR score. APGAR, gotta know it. Gotta know all these parts of it, okay? Appearance, pulse, grimace/irritability, activity or muscle tone, and then respiration. So unfortunately, yes, make a flashcard out of this. You gotta know the 5 areas of APGAR score. Okay, the total number is, so a perfect number would be 10. And you want to calculate this at 1 and 5, okay? So remember those. There are 5 things in the APGAR. A perfect score is 10, and you need to calculate the APGAR score at 1 minute and 5 minutes. So there you go. I'm not sure, I have not heard from any of my old students that this specific question will be on the National Registry, as in they're going to describe a baby to you and you have to figure out the APGAR score, but it may happen. So if you are a flashcard person, this would be a good thing to be familiar with. Okay, so we want to do that APGAR score. We want to suction stimulate the baby, check that pulse, assess skin color, all that stuff. All right, we just already talked about that. Got to get BVM, CPR on if you need to. Okay, we're going to talk about some abnormal deliveries now. So this is when, unfortunately, things have not gone the way we wanted them to go. So a breech presentation is usually when the buttocks are going to come out first, and that obviously can be pretty complicated. It takes longer, and so you will usually have time to transport the mother to the hospital. Now, if the buttocks have gone through the vagina, now you got to do your best, and there's some complicated maneuvers you can do to kind of get those legs out of there. But either way, you want to get ALS to come over, and you want to call medical control, because this can be a pretty common delivery. However, the delivery process itself is the same. It's just you're assisting the baby coming out. Now, as the baby is coming out, we want to make sure that we can make a V with our gloved fingers, and that can kind of keep a little bit of separation between the baby and the vaginal wall. Okay, limb complication, or another complicated delivery can be limb presentation, and these are pretty hard. They can usually not be delivered in the field. This will probably have to be a C-section baby, so transport this patient immediately, cover it with a sterile towel. never try and push the limb or pull it out, anything like that. Just hold what you got, go to the hospital. All right, prolapse cord is when the umbilical cord comes out first. And occasionally, the infant's head will actually compress the cord and then cut off circulation to itself. We do not want to push the cord back inside. We want to put the patient on a backboard in kind of a knee-chest position and kind of open up a little bit more room there, and do what you can to get the baby's head off of the umbilical cord. Spina Bifida, this is just something to be aware of, that you might see this. This is a defect in the spinal cord or the meninges, and they may actually be on the exterior of the body, and that's normally a neural tube defect, and that's something that happened at month 1 of the gestation. This baby developed spinal bifida. But it's immediately, it'll be a complicated baby when it's first come out. So just be familiar with what that is. An abortion is passage of the fetus or placenta before 20 weeks. And yes, you can have spontaneous abortions where there's a fetal demise. We'll kind of talk about that. It's the same idea where basically the baby inside, for whatever reason, didn't make it. And now the body wants to get rid of it. So you may see a spontaneous abortion where the mom just expels the baby. Multiple gestation, twins are generally smaller, but it's going to be just birth. It's just 2 births. It's not any more complicated. So it's same process, just 2 births. All right, abuse. Yes, domestic violence can result in miscarriage, premature deliveries, and low birth weights. So try to have a calm, professional approach and keep an eye out for any signs of abuse. Okay, and another thing that can harm the baby is addiction. So some women do drugs throughout their entire pregnancy, and that will result in premature birth weight or prematurity. So the baby will come out early. It'll be low birth weight, can have some severe respiratory distress. It can even not make it because of all the chemicals that it was exposed to. And then of course there's also fetal alcohol syndrome. Okay, so because of that, we want to make sure we're wearing full PPE and look for clues that you're dealing with an addicted mother. And sometimes they'll just straight up tell you that, oh yeah, I was doing drugs the entire time. All right, premature infant. So normally a gestation is about 9 months or 40 weeks, and a baby should weigh about 7 pounds. So write this down in your notes, circle it, highlight it, whatever you want to do. An infant who delivers before 36 weeks or weighs less than 5 pounds is considered premature. Okay, so that last bullet, make sure you guys understand that bullet. And there you go, there's just a picture of the 2 different babies. So you can see the premature is significantly smaller. They do require special care and resuscitation efforts. However, the good news is they usually make a full recovery. You can see there, infants such as small as 1 pound can actually have survived and developed normally. So they'll go in an incubator, they'll get some extra love from like the neonatal ICU there at the hospital, and a lot of these premature kids end up being just fine. Now, post-term, so this is pregnancies that last longer than 42 weeks, and these infants can be huge, sometimes weighing 10 pounds. And actually, a heavy baby like that can actually lead to a lot of problems for the mom during gestation and also during delivery. So, and things like that are going to be changed. So increased chance of injury to the fetus itself, probably going to have to get a C-section to avoid all those tearing and trauma. Infants may have an increased risk for meconium, aspirations being stillborn, those things, and infants may not have developed normally. Just depends on how gestation was. Okay, fetal demise. This is where the infant has died inside the uterus, and you may have to do a normal birth process. You may have to continue to assist the baby coming out, but it may not be alive. And it says there, do not attempt to resuscitate an obviously dead infant. Okay, you may have to deliver an infant without a sterile OB kit. So you do what you can to get eye protection, gloves, and a mask. I would wear all of those things for a delivery. Now, wipe the insides of the baby's mouth with your finger. Do not cut or anything the umbilical cord. And this is if you got nothing. So the placenta is going to come out, wrap it in a clean towel, and transport, and keep the placenta and the infant at the same level. So that way there's not this big fluid transfer before. Once again, bleeding more than 500 milliliters is considered excessive, and that is going to require extra attention. If that's happening, continue to massage the uterus and change those pads as often as possible. Now, do not discard any blood-soaked pads, and that's because we want to know, oh man, she filled up 10 pads or she filled up 1 pad, right? There's a big difference there. So keep track of the blood-soaked pads, and then put the woman in the shock position, administer oxygen, monitor those vital signs, and then transport her immediately. She's going to need some help. And unfortunately, those postpartum patients are at an increased risk for an air embolism, usually pulmonary embolism, because the body's trying to clot. The body's bleeding, it's clotting, and potentially that clot can detach from its clot location, move somewhere else, and end up as a pulmonary embolism. That was a quick down and dirty lecture on birth. I know it was pretty fast and there's a lot of information, but as far as chapters in this book, this is probably one of the longest chapters.